everyone. Good morning again. Thank you for joining us. We have a wonderful session today, and we will be covering the ISTH conference that just occurred a couple of weeks ago. And we have a wonderful speaker, Dr. Moll. He's from UNC Chapel Hill, professor of medicine. Just to give a little bit background about Dr. Moll, he's a huge advocate of thrombosis. He's practicing clinician and researcher and educator specializing in the thrombosis and anticoagulation. He co-founded the UNC's Clot Connect, a program dedicated to patient and public education on blood clots. His clinical expertise includes unusual thrombosis and special populations such as athletes and recently the astronauts, right? So he established the UNC's Athletes and Blood Clots program to provide advanced care, education, and research for athletes with clotting disorders. So these are the main objectives that we are thinking that we hopefully will cover. I will verbally read it. We will talk about how to optimize anticoagulation strategies in VTE, evaluate the reduce dose or DOACs for extended therapies, and we will hopefully will cover the updated criteria for APS diagnosis and management. And lastly, we will be going over the caplacizumab agent as a first-line therapy without plasma exchange, in addition to immunosuppression in the TTP patients. So those are the objectives hopefully we'll cover today. So without further ado, I will welcome Dr. Moll.
Well, thank you very much. So this is titled Best of ISTH in 2025, and really I've picked some selected clinically relevant abstracts. And I'm a clinician and clinical educator and clinical researcher, not a basic researcher. And what I will present are the abstracts that I found most striking and that somewhat influence my clinical management and help me take care of patients. And as mentioned, this will be about venous thromboembolism, antiphospholipid antibodies, and TTP treatment. Along the way, I will make some clinical take-home points. I have no relevant disclosures that will influence any of the content I make, but I do want to make a few thank you comments. Number one, I want to thank the following people for having made their ISTH slide sets available to me, so that I could get the details from what they really presented at ISTH. And then I understand and respect that the COBRA trial, the slides, and I will talk about the COBRA trial, it could not be made available to me by the authors because the data is embargoed while the manuscript is under review, and therefore the data cannot be shared. However, the slides that I will be presenting were publicly available on LinkedIn. So that is an important comment to make. And I've modified and simplified the slides provided to me by the authors, from the abstract authors, so that they're easier readable and that they are not quite as full of information, that they're a little more focused, but I have not changed any of the content. And then finally, this is self-understood for the majority of us, still worthwhile mentioning, abstract data are typically not peer-reviewed or published, the data themselves. So I typically do not change my clinical practice based on just the abstract data. I wait for the publication to come out, then that is peer-reviewed. It's in the common ability to review the data, discuss them, and that then eventually influences our management. So first of all, venous thromboembolism. Self-understood for the majority of us, but it's a colorful audience that listens to this and watches it. So I want to just ground us in the basics. Really, apixaban, rivaroxaban, dabigatran as a third agent I have not listed here. In the US, we use mostly apixaban, rivaroxaban. There's an acute phase where both drugs are used at a higher dose at different lengths, 7 versus 3 weeks. Then there's a treatment phase, which is up to 3 months and maybe up to 6 months with a standard treatment dose. And then after maybe 6 months, one goes into a secondary prevention phase where a lower dose of the direct oral anticoagulants can be considered. So I will talk about the acute treatment in just a second, which of these two drugs to use, apixaban versus rivaroxaban. But after the first 3 or maybe 6 months, the question also comes up how long to anticoagulate. And I want to put that into perspective so that we understand the studies that were discussed at ISTH. And this is a concept that I've used for a number of years, and I want to introduce to the ones of you who are not familiar with it. Anybody who stops anticoagulating after 3 months has some risk for recurrence. And for example, the patient with a major transient risk factor has a low risk for recurrence. That means they're at the tip of the triangle green zone. We treat short term with anticoagulation, 3 months, for example. And then people with an unprovoked, truly unprovoked proximal DVT or PE or DVT or PE have a higher risk for recurrence. That's a broad base of the triangle, red zone, high. Those people get treated with long-term anticoagulation. Men, higher risk for recurrence than women, but women still high enough that it's red zone, long-term anticoagulation for unprovoked VTE. And then we have the group of people in between, intermediate risk for recurrence. It's not low enough that we feel comfortable stopping. It's not low enough that we want to continue full dose. Individualized decision in those people, and more could be said, but I'll put it into perspective when we get to the trials. So when I see a patient in clinic, I identify the VTE risk factors. I put them roughly where they roughly fit in the triangle. So that then tells me whether the patient should be on long-term anticoagulation, short-term anticoagulation, or I don't quite know how to treat the patient. There's further decision-making with maybe the D-dimer, maybe some thrombophilia workup that needs to be done. So having said that as a background, which direct oral anticoagulant should we use or do we use in the acute setting? The dabigatran has come out of favor because of an increased risk of side effects gastrointestinal. It's much more cleared in the kidney, 80%, than apixaban and rivaroxaban. So dabigatran does not play much of a role, at least in the US. And edoxaban, the Japanese drug, used in some of the Asian countries quite a bit, but has not been marketed in the US, so there's not much that I can talk about edoxaban. But the two, apixaban and rivaroxaban, has been no prospective direct comparison. Is one of these two drugs better than the other, more effective or more safe? There was an attempt to have a prospective study called the COVID trial, but it was terminated in 2019 due to poor enrollment, which had clear reasons why the design was not meant to be good. There was also a warfarin arm, and at that time, people didn't really use warfarin anymore. So people didn't enroll because patients could have been randomized to receive warfarin, which none of us favored anymore at that time. So how do we decide in clinical practice? Well, some of us are used to one drug or the other, and that's fine because we have the experience with it. Some patients like the once daily dosing of rivaroxaban versus twice daily apixaban. The copay can be important or is often important. So sometimes my comment to the patient is, let's use a drug which is least expensive to you. And then from a bleeding point of view, it has not been clear whether one drug has less bleeding than the other because of the lack of prospective studies. But retrospective data, at least some retrospective data, have suggested that there's some advantage of apixaban with less bleeding risk, particularly less menstrual bleeding. And that seems to be a recurrent theme, that apixaban may have less bleeding. The trial that I found really one of the most striking, and maybe the most striking, is the COBART trial. And that's the one where I could not get the slides from the original authors, which is fine, because we have the ones that I have the ones that were presented at ISTH, but the expectation is that there will be a publication soon on this, and this will be nice. This compared the bleeding risk between rivaroxaban and apixaban in the treatment of acute VTE, called the COBART trial. It's a Canadian trial. What I also like about this study, it was not sponsored by a pharmaceutical company, but by the Canadian Research Institute. Now, the slides come, as I mentioned, from LinkedIn. And the study aim was to determine whether the patient with an acute DVT or PE with 3 months of apixaban is superior to rivaroxaban for reduction of clinically relevant bleeding events. And the answer is it is. And I'll show you the data. So it's a big trial. Apixaban, there were 1,345 patients enrolled, similarly on the rivaroxaban side. Randomized trial, huge numbers or quite significant numbers of people, and clinically relevant bleeding as a primary endpoint occurred in 3.3% of the apixaban-treated patients and in 7.2% of the rivaroxaban-treated patients, which is highly statistically significantly different. Now, you can take it further and look at the types of bleeding, major bleeding, or clinically relevant non-major bleeding. For example, here, apixaban 0.4% versus 2.3%. 2.3% also highly statistically significantly different. And then clinically relevant non-major bleeding, 2.9% versus 5%, also difference. So that is quite remarkable. Now, fatal bleeding was no different. An interesting, or not interesting, but noteworthy, recurrent VTE was the same in both groups, no different. So both are effective, and apixaban significantly safer. And this is shown also in curves in the presentation with clinically relevant bleeding. You see here much, this is, let me just quickly see, this is the rivaroxaban, much higher bleeding rate than with the apixaban, and recurrent clots were the same. Now, you could argue, and I would, well, maybe the rivaroxaban dose is overdosed in the acute setting. Keep in mind that rivaroxaban is used for 3 weeks at the high dose. And then after 3 weeks, we go down to the more standard maintenance dose of 20 milligram once daily. And apixaban is only used in the high dose for 1 week. So maybe rivaroxaban in this high initial dose is not really needed. And that's been a discussion for quite some time, which takes reference, and that leads a little too far for the discussion today, but maybe the rivaroxaban should not have been dosed once daily, given the half-life, but rather twice daily, the lower dose. But be that as it may, the FDA-approved indication of 3 weeks of the higher dose 15 BID for 3 weeks leads to a higher risk for bleeding. And the red zone here is the first 3 weeks of higher treatment. This is really where the big difference is. Now, even after 3 weeks, there is some, the slope of rivaroxaban is steeper than of apixaban, so there is continued a higher risk of bleeding, but whether that's really statistically significantly different or not, I don't know, and it doesn't look too impressive. But you also wonder, well, maybe the 20 milligram once daily is still a little too high a dose for the rivaroxaban there. Be that as it may, if it's used by FDA indication dosing, rivaroxaban clearly has a higher risk for bleeding than apixaban by this study. So the discussion in this presentation at ISTH was apixaban is safer than rivaroxaban in patient with acute VTE. 3 months of apixaban was superior to rivaroxaban. The primary outcome of clinically relevant bleeding events and recurrent VTE and death rates were comparable. What's the take-home point for me at this point? Well, for acute VTE management, apixaban may be a safer option than rivaroxaban. And I say maybe because this is an abstract only, but that sounds pretty convincing. And as I mentioned, it may have to do with the dosing of the rivaroxaban there. That may not be needed that high. But I clearly would not change the dosing of rivaroxaban if I'm using rivaroxaban. The other clinical considerations that we do when we choose a drug, I mentioned that once daily versus twice daily, that still applies. And at least in the US, the copay at the pharmacy for the patient is a huge issue and still needs to be taken into consideration when we use what drug. Because if the copay is too high and the patient doesn't take the drug, the whole data look different. But this is a really exciting trial. My questions then, should one switch patients who are already on rivaroxaban over to apixaban with a comment, well, apixaban is safer? Well, this is mostly referring to the patients who have been treated with rivaroxaban for some period of time, 3 months, 6 months. Should we switch them over? There's no strong indication. I indicated that maybe there's less bleeding even after the initial 21 days of high rivaroxaban, but that didn't seem to be too impressive, and we'll see what the data eventually show. And I wouldn't say that I would rush into that, but in general, my practice for the acute DVT-PE patient is I really prefer apixaban, and even for the longer-term prevention, my preference is to use apixaban. It didn't always used to be the case, given that the FDA approval of rivaroxaban, if I remember correctly, came before apixaban. So then the patient has been treated with 3 or let's say 6 months with anticoagulation and has an indication to stay on long-term anticoagulation, i.e. the patient is in the lower part of the triangle that I showed, in the red zone. And the question is, can we continue, or do we need to continue the standard dose, i.e. the rivaroxaban 20 QD or apixaban 5 twice daily, or can we lower the dose? And there have been 2 trials that you're well familiar with, most of you, that were published a number of years ago that looked at the lower dose. And based on those, my practice has been until early 2025 that I would consider the prophylactic dose in people at intermediate risk for recurrence where I didn't quite know, do they need anticoagulation or not, i.e. where I had equipoise, whether they need anticoagulation, because those are the patients that were initially meant to be in this study. That's how these studies were designed. And in the people who have a clear indication for full dose anticoagulation, I use to stay on long-term anticoagulation, I use full dose anticoagulation. Now I've used the prophylactic dose, particularly in the elderly at high risk for bleeding, which is mostly the elderly female, low body weight, if all 3 apply, or the people at high risk for bleeding. They've bled before, or maybe they have somewhat low platelets, some coagulopathy, liver impairment, maybe renal impairment, etc. Then the lower dose that I mentioned with these 2 studies from 10 years ago or so, that's the Amplify extension trial. You know them, but I briefly want to review them because that is relevant. They compared after the initial 6 months of full dose, they used the 5 milligram twice daily, randomized to 2.5 twice daily, or randomized to placebo. So you can tell that the investigators were willing to have the patient on placebo, so you wouldn't really use that these days for patients who have a clear indication to be on long-term blood thinners, i.e. the patient with unprovoked VTE. So really, clinical equipoise was the enrollment criterion. So for me, that means people in this intermediate risk of recurrence. In rivaroxaban, similar patient population, clinical equipoise, full dose after 6 months, prophylactic dose at 10 milligram QD or aspirin. And we knew aspirin was not all that effective. So, excuse me. So who was really enrolled? And that's interesting. Even though they said clinical equipoise, in the apixaban trial, 90% or more had unprovoked VTE. So there were people from this red zone area. And in the rivaroxaban trial, 40% of people had unprovoked VTE were in the red zone. So these 2 studies showed that the low-dose apixaban or low-dose rivaroxaban at 6 months can be used and is as effective as full dose and as safe. So with the equipoise patients, you can certainly use it, but people have also then argued, well, most people were unprovoked VTE. Here, almost half of them. So maybe, probably, possibly, that's even possible for people with unprovoked VTE, the people in the red zone. But really, the study by primary outcome was not about primary enrollment criteria, was not meant for the people who had a clear indication to be on long-term anticoagulation. So I had not fully embraced that I would use reduced dose in the unprovoked VTE patients. Then earlier this year, the views changed because of the publication of the RENOVE trial. And this is fully published. And I'll get to the ISTH abstract, which is a sub-analysis of this in a minute. But the RENOVE trial was a large French trial. Here you see they were randomized into two large groups of prophylactic, either apixaban, of half of the patients or so, rivaroxaban was the other half. So there were these people on those drugs were randomized either into the full dose or into the prophylactic dose if they had an indication for long-term anticoagulation. And follow-up is 3 years. And what you see is that no matter whether the people were on a full dose or low dose, they had a low risk for recurrence, and these two groups looked very similar. So looked equally effective with a low risk of recurrence. That's good news. Bleeding risk, and that's noteworthy. Low dose had significantly less bleeding, and here's the level of significance, than the full dose, 9.9% versus 15.2%. So you get as much benefit in efficacy as with full dose, but you get more safety. So that was really attractive in patients in the red zone, the lower part of the triangle, people with a clear reason to be on long-term blood thinners. And if you look at the net benefit, which is really taken together all the bad outcomes, bleeding and recurrent clot, low dose had a net benefit. It had less of the bad outcomes than full dose anticoagulation. So it was at that time that I felt, the unprovoked VT patients, it seems like we now have data, additional data, to say, yeah, I can lower those people at 6 months to the prophylactic dose. And I started to change my practice. And that was in March of this year when this paper was published. Now, I still wondered, and I've always wondered, about the severely obese patients, the BMI above 40. Can we also lower the dose in those patients? They are typically few in those clinical trials, particularly in the non-US trials. So what was remarkable, and this is my second highlight of ISTH abstract, is the RENOVE trial sub-analysis. And they looked at the extended reduced versus full dose anticoagulant use after VTE in obese patients. So sub-analysis of the RENOVE trial in obese patients. And what they found is a little worrisome not worrisome, but noteworthy, that the obese patients, and obese here defined as just above 30. At this point, they have not sub-analyzed for different BMI groups. Any obese patient, this is doing better on full dose anticoagulation. Here would be doing better on low dose. If you, first of all, look at the normal weight people, yeah, they have a tendency to have less recurrence. It's not statistically different, but a tendency to have somewhat lower risk for recurrence. Whereas if you are obese, there's a tendency to have a higher risk for recurrence than the low normal weight people. It's not statistically significant, but it really is close to it. So maybe the obese patients have a higher risk for recurrence if they are on low dose anticoagulation. From a bleeding point of view, we said that the main finding of the RENOVE trial was that there was less bleeding with a lower dose. And that's found here in the normal weight people. Clearly, they have less bleeding than with a full dose. But if you look at the obese patients, there's a trend towards less bleeding, but it's not statistically significant anymore. So maybe there may be a high risk for recurrence and they don't really get the benefit of less bleeding. And that's interesting. So if you look at the net clinical benefit that I mentioned earlier, the normal weight people, yes, they have less bad outcomes if they're on the lower dose of the drug, whereas the obese patients, they don't have any net benefit if you lower their dose. So whether you treat them with full dose or low dose, it doesn't matter, except they may have a high risk for recurrence, but they don't really have that much less bleeding risk. And then And this is I find this a little difficult, but the concept I want to highlight, and I'm really waiting for the full publication. Then they looked in the sub-analysis at the different BMI groups. BMI less than 25, that's really uncommon in the practice of the patients I see. BMI 25 to 35, and then the group that I'm really most interested in, where they get more and more obese, BMI above 35. And they looked at recurrent VTE, major bleeding, and the net clinical benefit again. And it's this graph here that I want to point out. This is the percentage of of the outcomes in the case of recurrent VTE. And what they've plotted here is with this arrow, the recurrent VTE is lower with a low body weight and gets a little higher with a BMI 25 to 35, and then it gets higher with a BMI above 35. And while this is statistically not significantly different because the numbers get also very small, what they show is a trend that the direction is the higher the BMI, the higher the risk for recurrence. Whether that's really statistically and clinically meaningful needs to be seen. And with the major bleeding, yes, you have the benefit, as we showed in the original big Renov, the full data set, less bleeding that's statistically significantly with a low dose, but that gets lost as the BMI goes up. Wide confidence intervals because there are relatively few people with a very high body mass index. And then the net clinical benefit, also this arrow shows, yeah, maybe you lose some of the net benefit. It's not all that striking because of numbers, but at least it's food for thought. Maybe in obese patients, lowering the anticoagulant dose at 6 months is not the right thing to do, particularly then when it comes to the BMI above 40 or 45, looking at the trend graphs that they show here. So their conclusion, and I agree with that, in patients with BMI above 30, reduced dose of the drug versus full dose was potentially inferior on the risk of recurrent VTE. It was not superior on the risk of clinically relevant bleeding, nor the composite of recurrent VTE and clinically relevant bleeding. And then they pointed out the dose effect that I showed you with the graphs with the lines with more recurrent VTE in patients with a higher BMI. So what does it mean for my clinical practice in July, and today is August 2025? Can we lower the drug dose after 6 months? Yeah, I feel comfortable in the people at intermediate risk for recurrence where I have clinical equipoise, I have amplify extension, Einstein choice, and Renov trial that show the low dose is at least as effective and overall seems to be safer. So I use the lower dose here. Obesity still comes into my thought with the severely obese patients. In the people with unprovoked VTE who should be on long-term blood thinners, yes, the lower dose seems reasonable in the number of people, but as people get more obese, and this is getting red means more and more and more obese, maybe we should be continuing the full dose. So maybe better not to dose reduce in the more obese patients. And is there a cutoff where, say, above this BMI, I would not use the dose reduced, a prophylactic dose? No, it's more a conglomerate of clinical factors and discussion with the patient. I hope that makes sense. I want to conclude the VTE topic with this and move to anti-phospholipid antibodies. And there was an abstract which was not really that novel, but it puts the anti-phospholipid antibodies back into more into the discussion. There's been a lot of discussion in the last 3-4 years, use of DOACs in antiphospholipid syndrome, or should we be using warfarin? And for most of the audience, this is probably basics, but maybe not for everybody. Antiphospholipid antibodies are a group of antibodies, and we have 3 different tests that established risk factors for thrombosis and pregnancy complications. The lupus anticoagulant, the anticardiolipin antibodies, IgG and IgM, not IgA, and the anti-beta-2 glycoprotein-1 antibodies, IgG and IgM, not IgA. And I've listed them here on the right in red. Some panels do all the other antiphospholipid antibodies, serine, choline, ethanolamine, and then there's the antiprothrombin antibodies, etc. But those are not clinically established risk factors and should not be used for in clinical practice. They should not be in clinical panels. They should not be used for clinical decision making. Now, the presentation at ISTH is titled Guidance on Laboratory Detection and Interpretation of Antiphospholipid Antibodies for the Diagnosis of Antiphospholipid Syndrome. And it's a detailed discussion, which clearly anybody running a laboratory and anybody dealing specifically with antiphospholipid syndrome patients, people need to be aware of this. But it also is full of information that is too much for the regular hematologist, oncologist, clinician. But they highlight, and this is has been known for obviously a long time, the antiphospholipid syndrome is made up out of the laboratory criteria that I mentioned, the 3 tests, and then the clinical criteria, thrombosis, obstetric complications, and they list them. And then, not infrequently, people with true APS have a variety of other issues: cardiac valve disease, renal disease, skin issues, neurological, pulmonary, musculoskeletal. And in the worst case, people have catastrophic APS. Now, the presentation at ISTH mirrors, I think, the publication that came out earlier this year. So this is available for all of us with all the details. And I advise everybody who deals with antiphospholipid syndrome to look at this. It's an update on the laboratory detection and interpretation of antiphospholipid antibodies with all the details that I mentioned. And I have picked a few just to highlight what may be clinically relevant in the more broad practice. They have a table in there, which I like. We recommend, this is the ISTH subcommittee, we recommend concurrent testing of lupus anticoagulant, anticarlipin, IgG and IgM, and anti-beta-2, IgG and IgM. That's what I mentioned earlier. These are the established risk factors. These are the tests that we should be doing. They do recommend, and if you are involved with the lab, that if you do testing and the patient's on a DOAC, the lab should have the ability to remove the DOAC so that you get a reliable test, because otherwise people get false positive lupus anticoagulant tests and we don't quite know then how to interpret them. So the lab should consider having a DOAC removal ability. I also like, or want to highlight that they say we do not recommend antiphosphatidylserine serine testing, which I mentioned to you, but also the antiprothrombin testing. They are not first-line diagnostic tests. They go on and say, well, in certain circumstances, they could be considered, and that gets very much into detail and a brain tweezer for most of the clinicians who deal with antiphospholipid antibodies. They also talk about what may come in the future and what's needed for the future. And I like that as a table. And on purpose, I've left most of the slide white here, but they have a huge list of research agenda to further optimize the laboratory detection of these antibodies in the diagnosis of APS, reflecting that with many of the aspects, some of the tests, the levels is poor standardization or suboptimal standardization of the antibody assays. Labs really need to know what they're doing. Even the interpretation, when we say a positive test is this and that, and the level is this range is mild or moderate or severe, it gives us false security if we take that black and white and say, oh, the level is 39, it's less than 40, so it's only mildly elevated. Because tests are relatively poorly or suboptimally standardized. Depends on what kind of ELISA people use, etc. So whoever, particularly in the lab, deals with this needs to be fully aware of this publication. The topic, APS, also gives me a chance to talk about the criteria that have been published, that were published 2 years ago, and that people increasingly are talking about, how to better define antiphospholipid syndrome. And I like the concept of these criteria, but I want to highlight these are research criteria. The purpose of these was to create a numbering system where we look at patients, how many points do they have, and I'll go through it in a second. The more points you have, the more you have clear, true, full-blown antiphospholipid syndrome. The less points you have, it becomes more questionable. Is this really APS or is this just coincidental antiphospholipid antibody positivity? And the purpose was to find the people who are really suitable for clinical trials, and then in clinical trials have people with a different point ranges and see, are there truly different groups that need different treatments, different responses? So it's really a future research agenda for the next 10, 15, or 20 years. So what these criteria do, and it's a combination of Europeans and American societies, with venous thromboembolism, for example, if your clot was truly unprovoked without any other risk factors, you get 3 bad points. However, if this was a clot associated with major surgery, for example, that's less likely antiphospholipid syndrome, so you only get 1 point. Similar with arterial thrombosis, if the patient has multiple arteriosclerosis risk factors, diabetes, hypertension, then the stroke is more likely due to arteriosclerosis and less likely due to APS, and you only get 2 points. But if it's a patient, let's say a 40-year-old, who has no arteriosclerosis risk factors and has stroke, that could be APS, so you get 4 points. Then there's microvascular disease, like microvascular renal disease, and if it's established by biopsy, kidney biopsy, that could well be antiphospholipid syndrome, you get 5 points. They also have obstetric assessments with risk factors, and it's worthwhile to look at that in detail, but time doesn't allow me to really fully talk about this. This is complex. And cardiac valves are in here. If you have thickening, you get 2 bad points, the varicose endocarditis with APS, and vegetations, true vegetation, you get 4 points. And thrombocytopenia, which is common in these people, ITP, you get 2 points. And then the laboratory criteria, the same ones I mentioned, lupus anticoagulant, anticardiolipin, anti-beta 2. The lupus anticoagulant is the strongest thrombotic risk factor. So if that is one-time positive, you only get 1 point. That may be transient positive, maybe even false positive. But if it's persistently positive, you get 5 points. And then anticardiolipin, IgM, many people think is maybe less thrombotic and maybe less relevant than IgG. So IgM only for either anticardiolipin or anti-beta 2, you get 1 bad point. If you have IgG and it's moderately positive, and moderately they call 40 to 79, realizing that there is variability between different assays. Moderately positive, you get 4 bad points. It's highly positive, you get 5 points. And if you're highly positive for both of these, anticardiolipin and anti-beta 2, you get 7 points. So you can see how a triple positive patient would get lupus anticoagulant 5 points, and then down here it could even get 7, so it could have 12 points here. So these are the levels that I mentioned. I think this is a nice concept to think what true APS may be. I don't count this up in clinical practice. I don't find that helpful. But I do think about these different categories. I look at the labs, I look at the values. So by gestalt, I do come to a similar conclusion and numbering system than they do. So what is the question to the clinician other than to make the diagnosis? Well, first of all, the question is, does this patient have antiphospholipid syndrome? Because we talk about management, maybe longer-term blood thinners, maybe switch to warfarin rather than use the DOAC. So we do want to know, does this patient really have antiphospholipid syndrome, or are these antibody titers that are clinically irrelevant? The titers are not very pronounced, they're just mild. They were one-time positive. It's only an anticoagulant IgM of 25. And the clot was associated with arthroscopic knee surgery. So that we need to be clear about. And the next question the clinician asks, whom do we test? And in patients with venous thromboembolism, I think about antiphospholipid antibody testing in the people in the middle of the triangle, this intermediate risk for recurrence, where I don't know what to do. Excuse me. And I want any reason to say, yeah, this patient should really be on long-term blood thinners. And if the patient have clearly positive antiphospholipid antibodies, repeatedly positive, well, that's antiphospholipid syndrome, then we need long-term anticoagulation. But if they're negative, maybe that moves them somewhat more into the green zone and would be one of the reasons to consider stopping anticoagulation. I also use a D-dimer for clinical decision-making. Negative D-dimer pushes them up, a positive D-dimer down. But it's also intermediate risk where, as I discussed earlier, we might not stop anticoagulation, but just use low-dose anticoagulation, the prophylactic dose. So really, antiphospholipid antibody testing here helps me to push the patient into the red zone if they have these antibodies and repeatedly and clearly positive. And in patients with unprovoked VTE, I did not used to be as liberal to test for the antibodies because those people needed long-term anticoagulation anyway. But now, these days, the question comes up, should those patients be on warfarin or is it safe to be on a DOAC? So I find myself testing more frequently the people with unprovoked VTE for antiphospholipid antibodies. And if they are triple positive, then I would suggest probably this patient should be on warfarin. And I get to the management in a second. But because of treatment implications, I tend to test people with unprovoked VTE these days more liberally. And then unexplained arterial thrombosis in the younger patient, I almost always do antiphospholipid antibody testing because why does a 32-year-old without any arteriosclerosis risk factors and no AFib, et cetera, rule out other things, develop a thrombosis? I want to assess for antiphospholipid antibodies, and I may then treat the patient if they're clearly positive with anticoagulation plus aspirin, and I'll get to that in a second. At what time to test for the antibodies? Well, that's unclear. It may be worthwhile. It may be. I don't have a strong statement that this should be done. Anticoagulant and anti-beta-2 antibodies at the time of the acute clot. Why? Well, if they're clearly positive, then they're double positive. And then you start to wonder, well, maybe if it's repeatedly positive eventually, maybe they should be on warfarin rather than a DOAC. But at that time, you don't know whether they're repeatedly positive, except if they're strongly positive and positive for both anticoagulant and anti-beta-2, probably more likely they are going to be positive again in 3 months. And then you would label them with antiphospholipid syndrome. And then you can think about, should we use warfarin or should we use a DOAC? Lupus anticoagulant, as the ISTH document presentation at ISTH showed, excuse me, as the ISTH presentation showed, the lab should have a neutralizer. That would be nice to get a reliable lupus anticoagulant. If not, maybe it's best to test the patient when they're at trough with their DOAC, so that the effect on the lupus anticoagulant is minimal, if present at all, or if one wants a reliable value, the patient needs to have been off DOAC for maybe 3 days, so it's completely gone, and you get a reliable lupus anticoagulant. Food for thought about the testing. And then treatment, that's really where the big question comes in for either venous arterial events. If they're triple positive, the studies in the last 4 years have shown that warfarin is probably a better choice than a DOAC. And I say probably, even though some of the guidance documents state clearly warfarin should be used. But warfarin has a high failure rate in antiphospholipid syndrome. We know that. Ortel at Duke has published on that. People with APS and arterial clots, they have a 6% failure rate. 1 in 15 people have another thrombotic event on warfarin. People with venous thromboembolism and APS have a 15% failure rate, 1 in 6 on warfarin. So warfarin is not a great choice in antiphospholipid syndrome, which is not that surprising given that it's an autoimmune, probably inflammatory disorder. But warfarin is not the great choice. And the trials that have been done, the 4 prospective trials and meta-analysis that has been published, which I've listed here as a reference, they have some bias to it, which I've discussed in detail last year. So warfarin is not necessarily the best choice, but in triple positive patients, I tend to use warfarin, particularly if they had an arterial event. Single and double positive, even though some people promote the use of warfarin, I don't think that's appropriate given the data that we have. DOACs may be okay, particularly in the people who have used the DOAC already for the last 2, 3, 4 years. They have APS, had a clot, have been on a DOAC for 3 years, have done fine. I do not drastically switch them over to warfarin. I discussed the warfarin trials, but probably would have them remain on DOAC. Arterial clots and APS, I've already mentioned that I typically choose aspirin and anticoagulation because the best treatment is not known. There's one nice randomized trial, and I've listed it here for your reference, that showed that lends support to the fact, to the comment that maybe aspirin and anticoagulation is the best choice. These are often young people with stroke or heart attack. They're at low risk for bleeding because they're young. So the combination here for the first 6 months and then see how they do. Bleeding is not an issue. Continue the combination and reevaluate every so often. That's my classical approach. But it comes down to individualized decision-making and discussion, considering the referral to a non-malignant hematologist and coagulation specialist. And then I think really important is not to be dogmatic. Because so much of the diagnosis that I showed you and that the ISTH presentation and the publication showed, much of the diagnosis, there's so much variability and so there's lack of standardization. And patients have such a huge spectrum, which the EULAR criteria highlight now with the pointages, that we really need studies to have subgroups of APS patients and know which ones need what treatment. So even the comments on warfarin versus DOACs cannot be dogmatic. And that's why I use the terms like up here, may well be a better choice, and DOACs may be okay. All right. And then the third topic that I wanted to discuss, somewhat briefer, is TTP. And it's the typical TTP, the immune mediated, antibody mediated, not the congenital absence of ADAMTS13, but the antibody associated ADAMTS13 deficiency, classical TTP. Uncommon as it is in many people's practice, at the academic institutions, we do get these patients referred. And the drug caplacizumab, which I'll explain in a second for the ones who are newer to that, is being used in clinical practice as a first-line treatment often, not everywhere. And this clinical trial, which is noteworthy, really noteworthy, not published, so abstract data. And the first author is with a pharmaceutical company, but there are a number of, but there are also a number of established academic investigators. It's a very interesting and noteworthy study. Caplacizumab and immunosuppression, typically with rituximab, without doing plasma exchange in this TTP. So don't use Plex or the plasma exchange. That's an interesting, they didn't. Let's get to that. It's called the Mayari study. And for TTP, and these are the slides from the presentation, I've modified them some, modified not by context, by content, but just by wording and by looks. So there are 3 parts that are important in TTP treatment. Number 1, since the ADAMTS13 is low due to the antibody, one of the goals is to get it back up. And that's typically the purpose of the plasma exchange. Then immunosuppression is necessary. It's autoimmune antibody mediated, so we need to suppress the antibody formation, and therefore rituximab is being used and steroids at various regimens, but that's a classical treatment for TTP. Rituximab takes a while, however long, 2, 4, 6 weeks, to have an effect. And then since in TTP platelets are activated by the lack of ADAMTS13, we want to, and platelet clumps form and thrombosis, we want to inhibit that. And that's what caplacizumab does. So it inhibits platelet adhesion. So this is a regular antibody, and caplacizumab is what's called a nanobody. And I'm not a basic scientist, but this is a fascinating development where part of the antibody is taken only, which is referred to as VHH or single domain antibody. And that's the nanobody that binds to von Willebrand factor. So thinking about it, you have the blood vessel, you have collagen in the subendothelium, and von Willebrand factor binds to collagen and to the platelet on top, and then activates platelets and forms a thrombosis. So if you inhibit von Willebrand factor, you block the binding of platelets, and that's a platelet adhesion that's being blocked. So it's really a von Willebrand factor inhibitor. Makes sense, and it's a great development to have that. Certainly, it increases the risk for bleeding because you make the patient von Willebrand factor not deficient, but you block it. So the purpose of this study was to explore caplacizumab, efficacy and safety, as a potential first-line therapy together with immunosuppression, typically rituximab and steroids, but no plasma exchange given, no PLEX, or some people refer as therapeutic plasma exchange, TPE. It's a phase 3 clinical trial, open label, single arm, no control arm, multi-center trial, not published. Inclusion criteria: adults, clinical diagnosis of immune-mediated TTP, either an initial first episode or recurrent. And this is important, TTP needed to be confirmed by ADAMTS13 testing within 2 days. And only patients were enrolled who had clearly low ADAMTS13 levels. Now, this is a problem if people think I'm going to use this in my clinical practice. If your practice doesn't allow you to get ADAMTS13 levels in a timely manner, and you just have a suspicion that this is TTP, and we all know the suspicion, it can be a strong suspicion or mild suspicion. These can be difficult patients. It's nice to have an ADAMTS13, but this study only looked at patients who had clear immune-mediated TTP with a low ADAMTS13 level. Key exclusion criteria were the people who had severe TTP, and the severe, if listed that here, had either severe neurological symptoms or cardiac disease, had significant renal impairment with a creatinine above 2.3, congenital TTP obviously excluded, or they had active bleeding or high risk for bleeding, which makes sense because you make them von Willebrand factor deficient or inhibited. So that all makes sense. So the severe TTP was excluded. People were screened. They had the ADAMTS13 level back. They did talk in this presentation about what ADAMTS13 level was considered to be low, that they would call it TTP. I'm not going to talk about that. You may have different criteria, but you can look at that once this comes out as a full publication. But clear TTP with low ADAMTS13, and then people were treated with daily caplacizumab and immunosuppression, typically rivaroxaban and steroids, rituximab and steroids, as I mentioned. And the duration of treatment was up to 12 weeks. And then there was a follow-up period at 12 weeks, so 3 months follow-up. The primary endpoint, and I'll focus on that, is how many patients achieved remission, a sustained clinical response, without needing plasma exchange. So this is really the big goal, to do away with plasma exchange altogether, with all the effort that goes into that, the cost and the potential side effects, and to just use the caplacizumab. That was the goal. How many people did that lead to remission? A number of secondary endpoints that eventually can look at it, and we can look at it when it's published, proportions of this and that, but clearly adverse events important. Screened were 58 people, then consented, 56 enrolled that met the inclusion criteria, 51, and then there's a modified intention to treat analysis, and that's the main one with 46 individuals, patients included. That's the number of people we are looking for. Who were they? Well, classical TTP patients on the middle-aged side, 46 years, a little predominance of females, 70%. That matches what we see here. Few elderly people, which have a high risk for bleeding, etc. Platelet counts were typically 19,000, but there was a range, a median 19. And then this is the NMTS13 level, which I have to say I don't fully understand what they meant with a 0.5. I think this is the percentage, but 0.5 is an odd. Typically, we get an NMTS sort of level of less than 10 and not this high sensitivity down here. But be that as it may, it's a low NMTS13 level that's in keeping with TTP, how it's defined where you practice. And then this is interesting. Initial first episode of TTP, 54% of the individuals and half of the people came in with a recurrence. They had had TTP before. A number of them had had caplacizumab before, 1/3. And then rituximab was given in almost all the patients, 95.7%. And this is what happened. Of the 46 patients, 43 went into remission without ever needing plasma exchange. Wow, that is pretty remarkable. 3 patients did switch over to plasma exchange for various reasons, because they were getting worse. But that's a really minority. And if you have plasma exchange available, you can start with this, or they did start with this, and then move over. They talk a little bit more in detail about these 2 patients. I did not find it helpful here at this stage where we don't have the full publication. Platelet counts, how quickly did they respond? This is the platelet count response here by the time people had normal platelet counts. Let me move over here to tell you more than 75% of the patients achieved platelet count responses within 5 days after the caplacizumab dose. Quick. Medium time to platelet count response was 4. Safety, well, you make them bleed more easily. So the main one is these serious adverse events happened in 14% of the people. 6% needed to stop the caplacizumab. And then major bleeding events, including bleeding into critical organ, life-threatening or fatal bleeding, that did not happen. So while there was some bleeding, the major bleeding was not an issue. So conclusion of these authors, caplacizumab and immunosuppressive therapy without first-line plasma exchange is safe and effective for a high number of patients with ITP who do not have severe TTP. So my final conclusions, clinically, how do I use this? It would be very desirable to have an NMTS13 test quickly available at your institution and our institutions to confirm TTP diagnosis before giving caplacizumab to confirm that the patient really has TTP. Otherwise, this may not be the right choice. Wait for the full publication, I think, is so important in a study which is relatively small, selected people, data, particularly the adverse events you really want to know about, the bleeding issues, the steroid therapy, etc. And it's currently only an abstract. Immunosuppression needs to be given, that we knew, but this study highlights that. Rituximab was given to all of them, almost all of them. And caplacizumab without plasma exchange may be a good option in patients with milder TTP, which is stable. The patient is clinically looking good. Laboratory-wise, they don't have multiple organ involvement such as renal failure, etc. With that, I thank you very much for listening and watching.
Okay. Great, Stephan. I mean, I think you made a lot of provoking ideas, especially the Mayari trial. Hopefully, the full publication will allude on that two patients, as well as because initially in the United States, we started using the Kaplan on the severe patients. I mean, despite the European colleagues being used the caplacizumab in every TTP patient, but it's interesting to see this without plasma exchange and huge benefit. Again, full publication needs to be outlined. There are a couple questions on the Q&A. I have a couple questions, but I will ask the posted question first. Do you usually lower the dabigatran dose after the 6 months for secondary prevention?
The dabigatran is not lowered. There's no study in VTE that has looked at dabigatran at full dose 150 BID versus a lower dose. So if your patient is on dabigatran for VTE, the dose is not lowered.
Okay. And if you have clinically relevant bleeding, I'm assuming the question was for that on rivaroxaban, do you lower the dose or you just switch to apixaban for secondary prevention or primary too?
Yeah. So allow me, and I apologize if this is self-understood, but in clinical practice, I often see it's not self-understood. The question first is, why did the patient bleed? And bleeding is typically multifactorial. Identify all the risk factors. Was the patient on the appropriate dose of whatever drug they were on when they bled? How's the renal function? How's the liver function? What is the platelet count? Were they maybe on aspirin as well and they shouldn't have? Were they taking ibuprofen? So that you can really modify the risk factors without too much initially focusing on just the drug made this patient bleed. It's multifactorial why people bleed. But if everything was appropriate and you've addressed everything, and you say, well, the patient bled on rivaroxaban and needs to be on some anticoagulation, question is, what dose did they bleed on? If it was full dose and you're beyond the first 6 months, or even beyond the first 3 months, because probably you can use the lower dose at 3 months even, I might lower the dose of rivaroxaban, or I would say, well, apixaban in general appears to be probably a safer option. Switching to apixaban would be a really good option. And then the question would be, do they need to be on full dose or do you switch to half dose? So there are multiple parts of the decision making.
Okay. I mean, one more question I have to respect your time. For the Renovi trial, have they looked up the major bleeding, clinically relevant major bleeding among those subgroups, or they have not analyzed that?
You mean the subgroups of apixaban versus rivaroxaban?
Right.
Yes, they did. And I think that was in the supplements of the original paper.
Okay.
And it was with both groups that you had less bleeding with the lower dose of apixaban versus full dose of apixaban, lower dose of rivaroxaban versus full dose rivaroxaban. And that sub-analysis did not suggest that apixaban would be better than the rivaroxaban.
Okay.
Which is a really nice and interesting question and data points that from the Renove trial, the full publication, I came out thinking, rivaroxaban may not be, from a bleeding point of view, worse than apixaban. But that's really beyond the first setting, the first few months, first 3 months, because that's where the recent trial looked at, which is really the point. Maybe the bleeding risk has a lot to do with the rivaroxaban being dosed too high and too long for those initial 3 weeks. And even long term, maybe the 20 milligram is too much even as a full dose, but the 10 milligrams is a pretty attractive dose.
Okay. And just one more question and then we'll adjourn. What is your dose adjustment for, because you mentioned about kidney failure. I know that we don't have that much data other than just anecdotal, some retrospectives. Do you dose adjust for ESRD patients?
So in patients with renal impairment and end-stage renal disease, so GFR less than 30 or renal dialysis, the only one I use, and that should really be used, is apixaban, not rivaroxaban. Rivaroxaban is cleared more in the kidney than apixaban, and all publications show that apixaban, if anything, would be the drug to use. And apixaban I use in renal impairment patients, and there are publications, and I strategize. We do know that in dialysis patients with severe renal impairment, apixaban levels are higher compared to people who have better renal function. But in the heavier, younger, lower risk for bleeding patients, I tend to use the full dose. In the more fragile, higher risk for bleeding, I use the lower dose, even in the first 3 and 6 months. That's the point what I'm making. And eventually, it's attractive to switch any of these to the lower dose. But in the first 3 to 6 months, in the more fragile, higher risk for bleeding, renal impairment, I would not use the 10 milligram BID apixaban in the first week. I might use the 5 BID. Then after 1 week, I might not use the 5 BID, but rather the 2.5 BID. Whereas in the more sturdy patients, I would use the standard dosing.
Okay, great. Thank you so much. I mean, I really appreciated your honest insights, and we look forward for those full publications. Again, thank you for everyone joined us. We will have session next week for acquired hemophilia. Looking forward to post again. Thank
Can
you.
I ask 2 quick questions?
Yes. I mean,
Okay, very quickly, and thank you so much. This was a wonderful talk. In a patient who has APLS and is being anticoagulated, and you're following the patient, and after a couple of years, the APLS appears to clear, is it safe to stop the anticoagulation?
Good question. We don't know. So I would go back to why did they clot in the first place? If it was an unprovoked clot with the antiphospholipid antibodies, I probably would continue anticoagulation, but lower the dose, go into that. So when I say I go back to why they had the clot, where were they in the recurrence triangle? Where do they fit in? But sometimes I wouldn't immediately stop. Sometimes I have them come back typically 6 or 12 months later and repeat the test. And if it's again negative, I think that's more impressive then. I wouldn't just base stopping anticoagulation on one negative test because they can fluctuate over time.
Thank you. And my second question is, when I have a young patient, let's say a 30-year-old with a first unprovoked PE, the idea of indefinite anticoagulation, that could be 50 years. So what is your approach in that young, otherwise healthy person with first unprovoked?
My approach is in my mind, long-term anticoagulation. But I never use the term indefinite or lifelong because that's a scary term. I say for the next few years to come, reevaluation once per year, see what new studies come out, particularly the data is maybe the risk of recurrence different in the young person with unprovoked clot versus the elderly person with unprovoked clot. So I'd use the term longer term anticoagulation. Let's meet again in 12 months and new risk benefit assessment, talk about new studies and new drugs at that time.
Do you use D-dimer or factor VIII assay to guide your approach? Or, because I know Dr. Caprinzi talks about that.
So in the patient with an unprovoked VTE, I do not. I put them at the bottom of the triangle, high risk for recurrence, 30% over 5 years. You should be on long-term blood thinners with the data we have these days. However, if the patient then says, look, I don't want to be on it, I need to stop, then I would say, well, let's at least do a D-dimer and antiphospholipid antibodies, because if you're positive for either one of them, then you have even more concern to come off anticoagulation. If they're negative, I still don't support that you come off, or I don't like that you come off. But if you decide to come off, then at least take an aspirin because we know that has some a protective effect against VTE.
Very good. Thank you so much.
Okay, appreciate it. Thank you again. Appreciate it. Q&A session answers.
Thanks very much.
All right, bye-bye.